Welcome to this education program on informed consent for healthcare professionals. Across this series of short segments, we will cover the standards, the responsibilities, and the practical skills behind obtaining valid consent. This series is for every professional who obtains, verifies, or witnesses consent: physicians, dentists, nurses, and allied health. It is built on national guidelines and evidence-based standards. Our objectives are to define consent, identify who obtains it, apply documentation rules, manage special situations, and use tools like TeachBack. Section 1 lays the foundations of informed consent, the ethics, the legal requirements, and the fundamental definitions that govern clinical practice. Informed consent is critical because it exists at the intersection of ethics, law, and patient safety. It protects patient autonomy, satisfies regulatory requirements, and promotes safer care. Treating a patient without required consent is classified as a clinical error. The regulatory framework for consent is built upon 4 layers: the national Saudi Guidelines, international JCI Standards, national CBAHI Standards, and your specific hospital policy. Always remember that your hospital policy serves as your operational reference. The most important concept in this video is that informed consent is a process of communication between clinician and patient. It is not merely a signature on a form. The patient must receive information, ask questions, and make a free, informed decision. The doctrine of informed consent was built through 3 landmark legal cases: Schloendorf in 1914, Salgo in 1957, and Canterbury in 1972. These cases established the core principles of patient permission, the duty of risk disclosure, and the reasonable patient standard for materiality. Consent is a process, not a single event. It follows 5 stages: discussing in plain language, inviting questions, checking for understanding, ensuring a voluntary decision, and documenting the process in the medical record. Studies show a significant, quote, conversation gap in clinical practice. In many cases, while a signature is obtained, the meaningful discussion required to meet the definition of informed consent often goes missing, leaving patients without true understanding of the risks. In clinical practice, there are 4 primary types of consent: general consent for routine care, implied consent for low-risk cooperation, written informed consent for procedures, and emergency consent for life-saving interventions when other forms are impossible. General consent covers terms and conditions at admission, while implied consent covers routine care given through cooperation. However, remember that implied consent does not replace the duty to explain what you are doing and why. For high-risk treatments, surgery, and anesthesia, written informed consent is mandatory. It must be obtained by the performing clinician, completed before the intervention starts, and the patient always has the right to receive a copy. In Section 2, we explore the 5 essential components that make a consent valid: capacity, disclosure, comprehension, voluntariness, and authorization. To be valid, a consent must satisfy all 5 of these components. If any one is missing, the consent process is considered incomplete. The first component is capacity. This is a clinical judgment made by the person obtaining the consent. Be aware that sedation can impair capacity, and you must always assess and document the patient's status before proceeding. Next, who cannot consent for themselves? This includes minors, unconscious patients, those with acute psychiatric illness, and individuals with severe cognitive impairment. For these patients, their rights are exercised through a guardian or representative, according to the hierarchy we will cover in Section 3. What must you explain during disclosure? There are 7 key elements: the condition, the treatment plan, risks, the clinician's name, alternatives, blood transfusion where relevant, and a genuine opportunity for the patient to ask questions. Risk quantification follows specific guidance. Disclose serious complications with a likelihood of 1% or more, and minor complications above 5%. For high-risk procedures where serious complications exceed a 50% probability, provide an explicit, detailed explanation and document that discussion. Comprehension is the ultimate goal. Use plain language, support your discussion with visual aids, and allow sufficient, unpressured time for the patient to reflect. Always verify understanding by asking the patient to explain the plan back to you in their own words. Evidence shows the TeachBack method works. Studies confirm it improves surgical comprehension and retention of discharge instructions. Yet, it remains underutilized. Make it a habit. Just so I know I explained it well, can you tell me in your own words what we agreed? Voluntariness is essential. A pressured yes is not valid consent. Do not force capable patients or their relatives, and ensure that a patient's refusal of a procedure does not impact their access to other necessary care. Authorization occurs through signatures. Sign only after the explanation is complete. Electronic signatures are preferred, though thumbprints are accepted if verified. All dates must match. Times must fall within 10 minutes of the first, and paper forms must be scanned into the electronic record. Witnessing requirements depend on the consent type. General consent requires one hospital employee witness. Informed consent requires 2 witnesses, one of whom may be the clinician explaining the procedure. Witnesses attest to the signatures, not the content of the discussion. Section 3 details the responsibilities of the clinical team and the hierarchy of decision-makers when a patient cannot provide their own consent. Whoever performs the procedure must provide the explanation. Delegation is only for operational necessity and to similarly qualified peers. Nurses verify that consent is present but do not obtain it, and they must report any patient hesitancy to the proceduralist immediately. The court case, quote, Schinell v. Toms, provides a vital lesson. The duty to obtain informed consent is non-delegable. Support staff can reinforce information, but they cannot replace the performing clinician's essential conversation with the patient. Regarding the hierarchy of decision-makers, the capable patient is first. Second, a patient-appointed representative, if capacity is confirmed for both. Third, the legal guardian in the national order of precedence. Fourth, the facility committee or judge when no guardian is reachable. If no guardian is available, a facility committee, comprised of 2 specialists, an administrator, and a social worker, convenes. Guardianship ends when a minor turns 18, when consciousness or sanity returns, and proxy registrations expire at the first adult encounter. Section 4 covers documentation, procedure lists, and the formal process requirements for maintaining valid consent within the medical record. The minimum set of procedures requiring written consent includes surgery, anesthesia and sedation, blood and blood products, and any high-risk treatment defined by your facility. These requirements align with JCI and CBAHI standards. This list covers common procedures necessitating formal consent, including endoscopies, biopsies, and radiological interventions like CTs with contrast or interventional procedures. Other items on the list include chemotherapy, central lines, and lumbar punctures. Always defer to your facility's specific list. Anesthesia and blood products require paired, separate consents. Anesthesia consent covers all sedation types, while blood consent is needed whenever bleeding is a risk. Only specific, chronic conditions allow for a 1-year blood transfusion consent. Otherwise, each series of transfusions requires a new form. Your documentation must contain 10 key elements, ranging from the hospital and department details to the full, non-abbreviated procedure name. It must identify the clinician, describe the discussion, list signatures for the patient, clinician, witnesses, and interpreter if used, and note the validity period. Why does meticulous documentation matter? Because in legal disputes, courts ask what the patient was told, not just what was done. Studies link communication failures and consent deficiencies to a large portion of malpractice claims. Your documentation is your primary defense. Practice good form hygiene. Complete the English section in full, never use abbreviations, and handle corrections by drawing a single line through the error, marking it error, then signing and dating it. If a clinician section or label is incorrect, discard the form and start a new one. Validity periods are set by hospital policy, typically reaching 3 months for single procedures. A new consent is required if the patient's condition changes, consent is revoked, a different clinician takes over, or the validity period has expired. Consent can be revoked by the patient at any time before the procedure starts. If this happens, the existing form becomes null and void. You must document the decision under your hospital's refusal of care process, and if they change their mind later, you must obtain a new consent. Section 5 explores special situations where standard pathways are adjusted, including emergency care, treatment for minors, pregnancy, patient refusal, and the requirements for telephone consent and language access. In emergencies, you may proceed without consent only if life or health is at immediate risk and no representative is reachable. You must seek the concurrence of a second qualified clinician, document the clinical threat, and inform the family as soon as they are available. For minors under 15, the guardian provides consent. For those 15 to 18, both the patient and guardian consent. For pregnant patients, their own consent is mandatory. Abortion for fetal anomalies follows strict national guidelines, requiring a 3-consultant report and executive approval. When a patient refuses care, document the discussion of risks and alternatives thoroughly and never withdraw support. Telephone consent requires 2 clinical witnesses, one of whom must be a physician. Language barriers are handled by staff interpreters or qualified proxies who sign the form. Evidence shows that language barriers significantly reduce the likelihood of documented informed consent, even when interpreter services are available. Always prioritize the use of professional interpreters to ensure comprehension. This is a regulatory requirement, not a courtesy. Adopt these best practices. Use teachback to verify understanding, engage in shared decision-making, apply health literacy precautions, and conduct regular audits. These steps improve patient satisfaction and adherence to quality standards. Local data from Saudi hospitals highlights that while some patients feel pressured to sign, quality scores rise significantly when the physician explains the procedure personally. These findings underscore that a high-quality, patient-centered process is achievable. In summary, consent is a documented conversation. Ensure you involve the right people, provide full disclosure, know your specific lists, and follow the emergency protocols. Thank you for your commitment to these standards.